Okay, now it's recording.
Wonderful.
And you're back as the host.
Sorry, everyone. Awesome. So yeah, welcome to our presentation. We're doing physiotherapy and motor neuron disease. I am Nikki Cook and this is Adina McDougall. We're both physiotherapists who work for Better Rehab in the community setting. So we predominantly see people who are on the National Disability Insurance Scheme, and that includes a variety of different neurological conditions, including motor neuron disease. We both have experience working with people in all different phases of motor neuron disease, as well as both male and female participants. And yeah, we see people predominantly in the Gold Coast region. However, we do have physiotherapists in South Brisbane, North Brisbane, the Logan region, as well as interstate. So we have people, physiotherapists in New South Wales, Victoria, and Western Australia. So it's great to have contacts from all across Australia. We've been asked to present today on what physiotherapy looks like in motor neuron disease, but in particular exercise prescription. We'd like to thank Motor Neuron Disease Association Queensland for giving us this opportunity to present, to share our knowledge and our experience, and we do welcome any questions that anyone may have at the end of our presentation. Awesome, so if we get started. Wonderful. So as an overview of what we'll be going through today, so again, we will focus predominantly on the exercise prescription, but we will cover a few of the basics and what we do see, especially between the differences of early, middle and late stages. The important thing to remember throughout today's presentation is that everyone is different and someone may be in an early stage or a middle stage that has a particular symptom that's not listed. So we're just adding a couple people to the presentation. Wonderful. Welcome. So what is physiotherapy? So physiotherapy helps to maintain movement and function when someone is affected by injury, illness or disability. So we look at movement and exercise prescription. We provide manual therapy, education and advice. And that is a very generic kind of description of what physiotherapy encompasses. Whereas in motor neuron disease, we promote healthy, optimal and productive living in those diagnosed with motor neuron disease, irrespective of their disease state. So what some people don't realize is physiotherapists are involved straight away from the initial diagnosis all the way through to late stage. We'll go through that a little bit more.
So I guess more specifically with physiotherapy and motor neuron disease, we, number one, address the symptoms, which also includes maximising function and participation for those that have been diagnosed with MND to make sure that they are able to still do the things they want to do, function how they want to function as much as possible. We work really closely with other allied health professionals. So that includes things like your occupational therapist, maybe even your speech pathologist, podiatry, things like that, to make sure that whoever we're seeing is getting the highest quality care, because that does take a multidisciplinary approach. So we're pretty lucky here at Better Rehab. We do have that MDT team, and we are often all working together to support the one person. As you guys know, MND is quite variable in almost all aspects. Like Nikki was saying, no two people are the same. It's important for that reason that physio is there from the start. We are there throughout, and it's good to kind of keep touch with your physio, because when things change, it often means that what we're going to be doing is going to be constantly changing, adapting, to ensure that whoever we're working with is being looked after and is meeting their ever-changing goals. So as a bit of a summary with physiotherapy and MND, we have a significant role in the provision of aids and appliances. So obviously that is also with your OT. Falls prevention, providing education and advice, which often we hear that is one of the most helpful things for people that have been diagnosed with MND. The obvious one being prescription of exercise programs, pain management, and respiratory symptom management.
So if we look at each stage, in the early stage of motor neuron disease, it is defined where individuals are independent with their mobility, their function, and their activities of daily living. They experience muscle weakness in specific muscle groups, and they have activity limitations and participation restrictions. And if they're present, they're quite minimal. So the goals here in the early stage for physiotherapists is we want to try and keep those weakened muscles that have been directly affected by the MND process. We want to keep them as strong as possible. So this is what we call about maintenance. We want to try and maintain the muscle's strength for as long as possible. The next point where we want to strengthen healthy muscles that have not yet been affected, that's important as well, because sometimes people experience what's called secondary weakness, and that's where in their home environment, they will no longer be participating in as many activities. They're no longer doing the things that they usually do. So their muscles have weakened, not from their motor neuron disease process, but from actually resting and inactivity. So this is where these healthy muscles, we want to try and make sure they're being used as much as possible to maintain their strength for as long as possible. And this is going to help maintain independence and function. And straight from the get-go, we're providing advice and education. Just to paint the picture a bit for what an early stage participant may look like, one of my participants that I see, I'll give her an alias, her name's Tracy. She's a 42-year-old female, and she was diagnosed with motor neuron disease at the end of last year. So she experiences muscle weakness predominantly in her left lower leg. She does have mild weakness throughout her right lower leg, but it's pretty predominant over her left lower leg. She's still independent with her transfers and her mobility, but she does use a four-wheeled walker. One thing that she has noticed is she has experienced decreases in her balance. Her mobility's declined, and she has experienced some muscular stiffness, but her weakness in that left lower limb is the quite predominant symptom that she experiences. And recently she's had a couple of falls. So that's someone who I would say at the moment that I see who is in an early stage of motor neuron disease.
Okay, so we're going to go across to middle stage. So in this stage, people are experiencing maybe an increased severity of the impairments they already have, or potentially something new. They start to find their participation restrictions are more common. There is a bit of a progressive decline in function and mobility. And this is where your compensatory strategies and intervention, as well as assistance from others, comes into play. So for this middle stage, we still have that focus on strengthening or maintenance, like Nikki said. So the affected muscles, we're still trying to keep them as strong as possible. The unaffected muscles, again, we want to keep them as strong as possible, because they're the muscles that will be kind of leading those compensatory strategies and interventions. Again, advice and education is really important. Discussing different ways to do things so that people still can be as independent as possible. But we just thinking of different ways, different positions that people can use. We're starting to talk more about pain, fatigue, and falls prevention. We're providing a bit more manual handling training to carers and families. So again, talking about that compensatory intervention and dependence, we're kind of talking through different ways that maybe assistance can be provided to ensure that everyone is safe and that everyone's still functioning and participating as much as possible. And we're starting to look into things like braces, splints, and equipment if that hasn't already been looked into. So again, painting a bit of a picture, often in that kind of middle stage, mobility does start to decline, and potentially people are using a wheelchair or an electric wheelchair a little bit more. There's still independence with transfers and some activities of daily living, but there has been a bit of a change. So whether that be you're still able to transfer in and out of the wheelchair, but in bed you're finding it a little bit more difficult to mobilize in bed, things like that. So, and then also there's family members that are starting to ask a few more questions, you know, what's the best way that I can help, for example, Glenn do this transfer, how can I help him with showering in the morning and things like that. So that's more that middle stage. We are looking at the exercise program, but like I said, also starting to address more the pain and fatigue side of things and falls prevention.
And lastly, in the late stage, so individuals become totally dependent for mobility and function due to severe weakness. And that's usually in the upper and lower limbs. So they may experience symptoms such as dysarthria, dysphagia, and respiratory issues. They're the most common in the late stage. However, this again is different between different people, and in bulbar MND, sometimes these can be present at the first stage. So that's important to note. It's not only in the late stage. These aren't a strict format here. There's other impairments such as cognitive and psychological impairments that may also be present in different individuals. So the goal with physiotherapy in the late stage, we want to try and develop new goals. So this is around our preventative interventions. That's to prevent things like pressure areas, kind of preventable respiratory decline with appropriate equipment, and also manual handling and falls prevention as well with any transfers, making sure everyone is educated and trained appropriately. Compensatory interventions, again, bringing in assistive technologies and the most easiest way to do things from a physical point of view, and then restorative interventions. We're always providing that education, but it's probably really important here at that late stage so everyone is on the same page between the patient, the family, caregivers, ourselves, and especially the multidisciplinary team, because we want to make sure we're all working together. At this late stage, from my experience and Adina's experience, we do work very, very closely with the occupational therapists, the speech pathologists, Queensland Health, the support coordinators, and multiple different people. So it's a really big communication process, but yeah, it's really important here. Oh, sorry, and if I talk about someone here with a late stage motor neuron disease, someone like Alice Mark, he was diagnosed at the end of 2018. However, he's also diagnosed with other comorbidities such as he has bowel cancer and Crohn's disease. So he's also fighting multiple different disease processes. He has had quite a fast progressive motor neuron disease because of the other disease processes he has. He is a 62-year-old male, and he has quite significant upper, lower limb and trunk weakness. He's fully dependent with all of his transfers. He just doesn't mobilize, he doesn't walk, but he is able to sit in an electric wheelchair. He does have function of his right hand to be able to self-mobilize an electric wheelchair. However, he is unable to grasp objects. He can also use his fingers to press remotes and buttons. So that's also an independence that he has that we try and maintain as well. Recently, Mark has experienced a fall in the last 3 months where he's spent a lot more time in bed. That's because of an injury to his lower limb. He has unfortunately developed a pressure area to his sacral area, which is in his lower back. And so the interventions that we do with him are a little bit different again. So we'll talk about different things that we do with each of these different examples throughout the presentation today.
So just a bit of an overview of some of the symptoms that can be addressed through physiotherapy. So I guess they are the more obvious ones. And again, we're going to go into a little bit more detail, but that's things like your fatigue, muscle weakness, stiffness, cramping, pain, shortness of breath, and falls prevention.
I'd also just like to note here as well, it's pretty common that I get with the participants that I see, they don't see the point in physiotherapy because of the decrease in muscle strength over time. And that's just part of the disease process. But we look at a lot of different things other than the muscular strength. And I think when we provide that education, and we can provide education around pain and stiffness and the manual handling and education, there's heaps and heaps of things that we can be involved with. So that's why it's important that physiotherapy is involved from the start of the diagnosis all the way to the end. And these are just some of the examples that we can assess. So for example, one of them is pain. So it's normally caused by immobility, loss of range of motion, decreased support, weakened muscles, positioning difficulty, dependent edema, and acute injuries. So pain, we will prescribe programs that look at range of motion exercises, passive stretching, joint mobilization, and education around proper joint support and protection. So pain is something that comes up quite a lot with our participants, especially if the participant doesn't have the strength to be able to move the joint themselves. So this is something that we regularly assess for, and we're always looking at finding different ways to be able to assist them with their pain. Pain is something that we want to try and decrease as much as possible as well, because we know it can exacerbate depression, fatigue, and we want to try and optimize the quality of life of the participants that we see as much as we can.
Okay, so we're going to go through a bit of exercise now. It's important to note, and we'll go through this a little bit in more detail, that there isn't buckets of research out there, unfortunately, with exercise therapy and motor neuron disease. We have provided some references at the end of some of the sources that we've got this information from. So if anyone wants to do further reading, they're more than welcome. But what we do know is that exercise is supported through all stages and can help address the following. So we've got maintenance of joint range of motion, prevention of contractures. So that's when a joint might permanently stiffen from shortening of tissue in that joint. So we've got reduction of stiffness and discomfort. So again, your pain side of things, maintenance of circulation through active muscle movement, and optimization of function and quality of life.
So the different modes of exercise that have been acknowledged in different guidelines and the literature. So we've got the resistance exercises of the unaffected muscles. So straight from the get-go, we're looking at muscles that haven't been affected and trying to maintain their strength. So a grade 3 or above is a grade that we define as being able to resist against gravity. So these are particular muscles that we are focusing on to try and maintain their strength and keep them as strong as possible. Important to note here that resistance is always low to moderate load and intensity. It is contraindicated with motor neuron disease to do anything high load, high intensity, because we don't want to damage the muscles. We want to keep them healthy and strong. And so low repetitions, low weights, and it's always guided even between each session of the individual, depending on days of their fatigue, other things that may be going on. And yes, there's no particular recipe, but it's just low to moderate load and intensity here. The next point is our range of motion and stretching exercises. And then we have our aerobic exercises. So aerobic exercises at sub-maximal levels, they may be safe and effective in achieving therapeutic goals. So that's what the literature has reported, but again, there are many benefits to doing sub-maximal aerobic exercise that we will touch base on in the next coming slides. Aerobic and resistance exercises are more appropriate for those early to middle stages of MND and those with more slowly progressive disease. And again, exercise should be prescribed as soon as possible after diagnosis. So the first one here, if we're looking at a muscular strength focus, this is off a program we use called Physitrack, and it's something that we do develop our exercise programs from. These are just two examples that can be changed and regressed for each participant. So in the top left corner with the elbow flexion bicep curl with the weight, this is someone who still has that muscular strength in their upper limbs, but the bicep curl is a very functional activity that we're trying to target that uses large muscle groups in the upper limb, but also very important for lifting, holding, grabbing, all of those different functional activities. If the muscle has declined in strength and the participant is no longer able to lift weight, we then move to what we call just against gravity, just an active range of motion, and that's without any weight at all. And then that motion can actually be assisted by the next picture with a therapist by helping to assist the hand up and then down, because this promotes the muscle to continue to be used without the therapist doing the movement for them. It's important to try and use what muscular strength is available in each muscle group for as long as possible, because when the muscle activates, it creates a muscle pump within the limb. So that just helps with our circulation, it helps with pain, it helps with any joint stiffness, and we're just trying to maintain that for as long as possible. So there's two examples for our upper limb. In the bottom two is two functional exercises with our lower limb. So the sit to stand from the chair in the bottom left, that one is someone who's definitely in that early stage of MND. And that can be varied between different people with providing upper limb support, standing up to a frame, standing up from even a different heighted chair. There are different ways that we prescribe that. And also to bringing in assistance or standby assistance beside the person just to make them feel more comfortable or provide any assistance as needed. Sit to stands are very functional, hopping on and off the bed, on and off your toilet, in and out of a car, keeping those lower limb muscle groups strong. So the exercises that we do prescribe are very functional, and they're very targeted to the large muscle groups that we do want to continue to use. If the person is no longer able to stand with assistance, but they still have the muscle strength able to move their leg, we then progress to what we call knee extension and sitting, and that's just straightening the leg. So this is, again, good for that lower limb circulation. There's people that I see that this one's really beneficial for because they experience lower limb edema and swelling, whereas their main effects from the disease process of their MND have been more in their upper limbs. So they're able to move their legs freely, and this is prescribed to them to complete multiple times throughout the day just to help with their lower limb swelling, as well as doing ankle movements and elevation. So yeah, it's, they're just two examples. There's lots and lots of different exercises. For Tracy, who I spoke about in the early phase, as the example, she will complete a home exercise program similar to the bicep curls and the sit to stands at home in her living room. And yeah, so she does that 3 times per week at the moment. So that's just something that she does. And she also does things like sitting on the ground, moving her heels up and down. She reaches up overhead using those muscles around her shoulder and her neck and her traps. So any lifting activities. And she's also doing gripping activities as well. And they're all just to maintain those functional muscles that are used in everyday living.
So the next one we're going to go through are those range of motion and stretching exercises. So at times this is more targeted towards the middle to late stage. As you can see in the photos, again, like these have just been selected as examples, but assistance is provided in all of these exercises. So we're on the first row, if you can see, it has AA-ROM, which stands for that active assisted. So as Nikki was saying before, we still want, where possible, those muscles to contract. If they can't contract without the assistance to actually move the limb, then assistance can be provided by somebody else, whether that be a family member, support worker, someone like that. So again, we've got that kind of upper body example. If able, you can do those movements in sitting and lying down. And then if we look to the bottom two, that is a completely passive exercise. So meaning that there is no movement that can actively happen from the person. That movement is fully provided by somebody else. Now, again, you're kind of thinking, well, what's the point of doing these kinds of exercises? When we think about that pain, that stiffness, contractures, even swelling, moving, even if it is passively, is going to help all of those things. So the gentleman that Nikki was speaking about before, Mark, if movement wasn't applied to his joints, there's such a high chance that those joints will stiffen, that will cause him more pain and could potentially cause a contracture where no movement is possible. And how that can affect people is things like getting dressed, putting on a t-shirt. If Mark is unable to move his shoulders, those kinds of activities become really difficult and can become really painful, and overall can have quite a significant impact on quality of life. So although when you start to get to those middle to late stages and you're thinking, well, I can't do exercise, you can, but it's a different type of exercise and potentially something not as traditional as people think when they do think of exercise. So like I said, these examples kind of show there's different positions. It doesn't have to be lying down, it can be sitting down, it can be any muscle group. Again, we want to target those that are more functional. So the big arm movements, the big leg movements, but these kind of programs are often what we're teaching to the participant, but also obviously their family members, their support workers, anyone that can provide that assistance on a quite regular basis.
So the next point is the aerobic exercise. So aerobic exercise is an interesting topic because it's not well documented in the literature, but at that sub-maximal intensity, as we spoke about earlier, it can provide those benefits. And those benefits can be circulatory, so for your cardiovascular system, maintaining that respiratory health, and also just overall muscular endurance to keep that physical capacity going, to be able to walk across a distance or to be able to complete multiple things throughout the day and preventing that fatigue onset. Fatigue is something that does come into play when we are prescribing anything aerobic, but we find it's something that's often missed in people's programs because it's just not something you usually think of. So aerobic examples that we have provided to people that we see are walking programs. So that's with a walker, by themselves if they don't have a walker. And there's also those different supported mobility aids that can support the people who are walking. A standing program. So if someone has a drop foot, that predominant sided weakness, but they are able to stand by themselves with some upper limb support, a standing program is great for aerobic fitness because it requires the muscles to be able to hold them in a position and stabilize their pelvis and their trunk for a period of time. And this actually works the muscles, gets the blood pumping, and it really, really helps with that aerobic exercise fitness. The lower two are lower limb pedaling and upper limb pedaling. So in the top right corner, there's a little device there, and that's something that's really easy for us to provide to our participants. It's from a lot of different assistive equipment stores around a lot of like Gold Coast, Brisbane, Logan, and they're quite cheap. They're a low cost item. And depending on where the MND process has predominantly taken place, whether it's the upper limbs or the lower limbs, people will use these pedals either in their upper limbs or lower limbs as part of an aerobic program. And again, very low intensity. These people aren't working to maximum capacity. It's just very slow rotations and just trying to get that circulation pumping. Also really helps with working on our breathing techniques as well when we go through exercises like this, now deep breathing.
And so we kind of touched on this before, but it's really important when you're thinking of exercise and MND, that overwork versus underwork. And that's because, again, exercise in maybe a traditional sense, people are thinking of going for a half an hour walk or going to the gym for an hour or something like that. Whereas we often are recommending that it's several brief sessions throughout the day. So that could be even something as small as 5-minute blocks spread out over a whole day, maybe 4 times, something like that. And that is because the exercise program should never compromise that reserve required to carry out activities of daily living. And so what that means is you shouldn't be doing an exercise program and then being too tired or too sore to do anything for the rest of the day, or worse, for the day after that as well. It can impact having a shower. It could impact transfers, things like that are still really important. So it's good to work closely with your physiotherapist to determine what is a suitable amount for you, because it's going to change for every person, and be quite strict in sticking to that, because you might feel wonderful at the time and then the next day wake up feeling a bit sore and sorry. So that's something really important and good to determine from the start, and then, like I said, stick to that throughout. Or another consideration that's really important is rest periods. So often, you know, when you got your little numbers, you know how many you're doing, how many sets, but just as important to know is how long should I rest for? Even if you're feeling wonderful, again, if you jump straight into that set, you don't allow enough rest, you could be feeling a little bit sore or sorry afterwards. When you're doing the program, it's really important to monitor and adjust. So that could be monitoring every single time you do the program. Every day is different. Like Nikki was saying before, it can depend on how much sleep you've had, how much pain you're in, what activities you've done that day. So it's really important to monitor the program and adjust as things maybe get a little bit harder, as you start to experience different things. And again, that's why it's important to kind of touch base with your physio frequently to kind of update them on, oh, this has been happening now, do we need to adjust anything? And that program is easily changed and adjusted. So general education, when you're doing an exercise, is never to the point of extreme fatigue. That's when you're putting yourself at risk for injury. We really want to avoid that. So start at something comfortable, monitor it over a period of time, then speak to your physio if you feel like you can be challenged further. Know what the signs and symptoms are of overuse. The kind of most obvious one is pain, to be honest. If you're experiencing pain when doing an exercise, it could be that the muscle is to the point of extreme fatigue where it's starting to fail. That can be things like symptoms of fatigue, symptoms of stiffness. So again, if you're experiencing anything that you think is out of the ordinary, good to speak to your physio to determine if maybe you are kind of going to that point and overusing the muscles. And if you are experiencing those symptoms, it's important to stop and check in with someone and just say, hey, this is happening. Should I keep going, or do we need to change something? So yeah, it's exercise is wonderful. It's very important, but it's good to know your guidelines and maybe some of the things to keep in mind when you are doing that exercise.
So recommendations that have been provided by the literature has been quite limited. And unfortunately, with motor neuron disease, the nature of research, the research process, so that is across the board, and our high quality evidence does come from randomized control trials that go into systematic reviews. And in order to complete a randomized control trial, you need a large participant cohort over a period of time with usually a placebo control, and then there's the intervention. So it is quite difficult in an MND setting to conduct research in that manner. And also there's a lot of different MND, I guess, prognoses. So people they're very individualized. So the symptoms and people's function and their ability to participate is very different across the board. There's also limited numbers and spread out across Australia, so that can make it difficult. What we do know though, and there is motor neuron disease guidelines and available literature, and those are again provided at the end of the presentation if you want to do further reading. The general recommendations that they provide is that passive movements, they should be applied to all joints, that patients cannot move themselves. That's again to maintain that joint range of motion and prevent the muscular stiffness or shortening. education to carers, family members on passive movements and stretches is essential in ensuring that they're carried out regularly and properly. And in general, education, it's very important. We see that across the board. Individualized strengthening exercises during the early stages of motor neuron disease are probably effective in improving the function of patients and should be recommended. And moderate intensity endurance activity may delay the onset of spasticity. That's something that they have noted. And then there's active passive trainers or unloaded cycling that should be considered. And these are assisted bikes within the home that have a motor that help to start the process of the movement. So then you don't require the force or the muscular strength to get the cycling motion happening, but it's more a repetitive movement where you're set up in a safe environment and you're provided a movement over a particular period of time to complete. And that the research in that has been where spasticity is present. So that's just some of the dot points of what has been noted, other than things that we've spoken about in the presentation today.
And again, this is a presentation on exercise, but we just want to very briefly touch on the fact that physiotherapy is really important in respiratory impairments, and I guess to some extent will have a role to play with exercise. So some of the kind of signs and symptoms that you may experience or you may hear about are your shortness of breath, difficulty breathing when lying down, sleep disturbances, poor concentration, confusion, daytime sleepiness, morning headaches, fatigue, and then a really big one as well, your respiratory muscles are also muscles and can be affected. So it can affect your ability to cough and keep your airway clear, which is important when you're trying to prevent chest infections and things like that. So as the disease does progress, almost all people will eventually require some type of respiratory intervention. Physiotherapy can really assist with those manual techniques, breathing exercises, so again, another type of exercise, as well as any mechanical device to prevent and manage respiratory related issues.
Interesting topic is the hydrotherapy or aquatic physiotherapy. It's not something that's generally talked about with motor neuron disease, and it's something that was asked to talk about today, and it's a very interesting topic because I actually see one of my motor neuron disease participants in the pool and she absolutely loves it. So aquatic physiotherapy is movement and exercise for rehabilitation carried out in warm pools. So the physiotherapist will find the main problem, whether it's their flexibility, their strength, their walking, balance, or anything else, and then we'll create a targeted program in the pool to address those difficulties. Aquatic physiotherapy with motor neuron disease can provide a supportive environment for exercise, and this is because the water provides assistance and it actually is easier to move your limbs and do things like a sit to stand in the water or walk, where you may not be able to do that on land. So it is determined on an individualized basis though, because there are other things that we need to consider. Is there a history of seizures? Is there any open wounds? Incontinence, multiple things. So that is something that you need to discuss with your physiotherapist, but it is used. And my participant who I spoke about earlier, Tracy, she's the one who actually attends a pool on a fortnightly basis with me at the moment at a public pool. And the public pools are great because some of them have specific hydrotherapy pools, and they are equipped with a wheelchair accessible ramp into the facility and also into the pool. And the facility actually has a waterproof wheelchair that the participant will transfer onto and they can go into the pool. Tracy will walk down the ramp into the pool, but she knows that the wheelchair is there if she ever needs assistance. There's pool hoists, rails and seats in the pool, and some of them even have a plinth transfer area. So that's where you can get changed. If this is something that you are considering, that you want to speak to a physiotherapist about, it is really important to have those discussions and just see if it is appropriate for you. And also to call the facility prior to going, just to make sure if there is any supportive equipment or ramps that you are able to just make sure that they're there before you attend. What I do with Tracy in the pool is we have dumbbells and we do strengthening exercises. We'll do walking, squats, We will do lots of stretching as well, because she finds it difficult to bring her knee and her hips up in standing. So at the edge of the pool, she's able to do that all on her own. So it gives her a huge psychological boost. And she really, really loves this type of therapy, to the extent where at her home, her husband and herself have installed their own pool where she actually completes swimming. So Tracy is a unique person as well. She, different to everyone, she has a history in triathlons. She loves her swimming. It's part of her mental health routine. And she actually completes her swimming with some floats between her legs as part of her aerobic program. And she separates that throughout the day, as Adina was saying, separating the exercise so it's not too much load in one period of time. And yeah, she does really well. So that's something we're continuing to do. And yeah, if it is an option that's not generally talked about.
And so as we are talking about exercise, it's good to kind of think of exercise physiology. Similar to physiotherapy, I guess there isn't a lot of evidence specific to exercise physiology, but it is really important to notice, though, in the description that an exercise physiologist is a professional who specializes in exercise. So they are taught the knowledge, the skills, the competencies to design programs, make sure they're safe, and they're looking, the cohort they do look after are the acute, subacute, and chronic. So that it does include disability. I'd say similar to physiotherapy, if you're wanting to access exercise physiology and see if that is something for you, it's just good to try to find an exercise physiologist that does have experience in MND. I'm sure some of you might have had experience with physiotherapists that maybe didn't know a lot about MND, and it can be limited to then provide that care. So it's, I guess, similar across the board for any allied health professional. If you can find someone that does have the experience, they might be the right person for you. So that's all I can kind of say on exercise phys at the moment. Hopefully there's going to be more research in the future.
Wonderful. So that's all the information we are talking about today, but here are some of the references that we have used to obtain, and these are guidelines that we generally will review and go over for treatment program prescription with our participants. So if you are interested in any further reading, feel free to click on those links and go into those guidelines. So yeah, thank you very much for listening to Adina and myself. Please, we welcome any questions you may have. And so just giving you back the host, Stacey. Or MND Queensland, there you are.
Excellent. All right. So, if it, let me just see if I can unmute everybody. Have you actually given me black host? I don't seem to be able to do that.
It says you're the host on our side.
Okay. Right, well, if everyone can unmute themselves, because for some reason it is not allowing me to do that, I'll just try it one more time. Yes. Mute. Yeah, if you've muted yourself, then I can't unmute you. That's what the problem is for some people there. So yourself, but let's go straight on to questions then. Who's got some questions for Adina and Nikki?
I've got a question.
Sam.
Yeah. Where I still got fairly good mobility, but my downfall is my balance. Is there anything that I can do to improve that, or is that gonna decline all the way.
I guess balance is a bit of a funny one because everyone will experience a decline in balance naturally. It is one of those things that the old term kind of use it or lose it. So I would definitely encourage you, Sam, to actually do exercises that target your balance so that you're using it often. It's really hard to say whether it's going to get better, how long it might maintain for, what kind of path your balance will take. But if your mobility is good, then there's a good chance that if you work on your balance, that you'll find that when you are mobilizing, that you're starting to feel a bit more stable on your feet. So yeah, like I said, it's just balance is one of those things we don't often target. We don't think about when we're doing an exercise. So if you can start, I don't like to put a bit of a ceiling on what effect might happen.
And again, it's those general principles. If you keep the loads low, you do gentle exercise and you're not working into that fatigue, it shouldn't progress or decline the muscles any further to the point where they're damaged. It's just selecting gentle, low-grade exercises to complete those movements in, and then you're doing it nice and safely.
Make no mistake, everything is on a downhill slide.
Yeah.
I'm just trying to prevent it or slow it down a bit more.
The other thing you can do as well is with your physiotherapist is to talk about your mobility aids that you have been using, and just to see if there's anything that can help to make you feel more supported and less unbalanced. And so there are multiple things that can be implemented, and it's something even as footwear can be looked at, what you use to walk around with, and then also what you have supporting around you as well. If that has already been addressed, then yeah, the exercise program to specifically address those balance issues is something to look at. But yeah, we cannot unfortunately change the disease progression, but we can try and maintain what we can for as long as possible.
It'd be worth $1 million if you could.
If you find out, you let everyone know. Yeah.
I would, because it's a horrendous disease. It really is.
Thank you for asking the question and sharing. We appreciate it.
Yeah.
Does anybody else have any questions?
Yeah, I've got a question with regards to muscle wastage rather than weakness. That's something that you might be able to answer a question on, or because how can you differentiate between muscle wastage due to old age or MND? Is there a correlation there, or?
I guess we know that, like you said, as people age, they will experience more muscle wastage. Normally the wastage becomes secondary to weakness though. It's rare to have a muscle that just wastes if it's always being used or if it's always being exercised. So normally it is the kind of second part of the weakness. So how to differentiate if the weakness is age-related or related to the disease? If it's a very, very slow progressing disease, that differentiation would be very, very small and sometimes hard to tell what it is exactly. Sometimes with MND, it tends to be a bit of a pattern that people do notice, whether that is one side versus the other side. They might start to notice the muscles closer to their trunk stay stronger longer, and it's actually the muscles that are further away. So like in the muscles in your hands or the muscles in your feet kind of start to get weakened first. So potentially if you're noticing that the wastage is following that same pattern and it's not global, so it's not affecting all muscles evenly, you do tend to think, okay, that could be because of the disease. However, if it is a very, very global, quite slow, that you've noticed, oh, this muscle definitely looks smaller than it did, you know, a few years ago, then that could be more an age-related muscle wastage. But again, these are just some guidelines. I'm sorry, Ray, it's not a very hard and fast answer for you, but does that kind of help a little bit?
Yeah. I had a question that I'll probably be asking the neurologist. When you experience muscle wastage, say in your arms and legs, like in your arms, do they typically just affect your bicep and tricep, or just your tricep, or?
It really varied, unfortunately. It's really, really hard to pinpoint.
Sometimes different people that I have seen, if it's bicep or tricep, they're just the opposite sides of that group. So one will move one way and the other one will push something away in the other. If you were experiencing more muscle wastage in one muscle, like your tricep over your bicep, it just means that you were maintaining that strength to lift things rather than to push things or push it away. Every single MND disease process is different. So sometimes it can affect both muscles equally, but other times it can affect one muscle before the other. In regards to the muscle wastage, again, that's where the muscle will actually become smaller and there's less fibers within that muscle activating, and it's becoming smaller and smaller and becoming weaker. So with your neurologist, you can ask those questions, but it's not generally a recipe where it's going to always affect one before the other, especially between a bicep and a tricep.
Final question. During your presentation, you mentioned two words, dysphagia and dysphagia. Can you explain those two terms? I don't know what they mean. So.
Oh, of course. So dysphagia and dysarthria, they're both words that we use to describe dysfunction within our swallowing and our mouth and our talking. So dysphagia is where dysphagia, that's where we have issues swallowing. We may have impairment due to muscle weakness or another type of impairment. Usually with motor neuron disease, it's the swallowing, whereas dysarthria, it's the muscles that we use in our neck and within our throat to actually talk and communicate. So dysarthria is where we're having issues in communicating. Does that answer that one?
Sure.
Okay. Yeah, sorry about that. We should have made that one a little bit more clear in the presentation.
Yep. I'm good, yeah.
Wonderful. Any other questions? I think we've got 1 minute. Stacey?
Before we finish, I might say thank you, because Nikki and Adina look after a few of my clients. So thank you for the work that you do with my M&D clients.
I think, Andrew, will you ask the question?
I was just going to ask a question about the physiology of orthopnea.
I guess because MND kind of affects your muscles regardless of where they are. So one of those groups of muscles being your respiratory muscles. So often that orthopnea kind of refers to when you're lying in a more flat position and then having greater difficulty breathing. And the reason for that is when our body is more of a horizontal position, it's actually requiring greater strength to get air in because of the position of our body related to gravity. When we are more upright, we don't have that gravity to fight against on our trunk. So it's often a bit easier to breathe. When we move into that type of position and our muscles are weakened, it can be harder to get air in and we develop that shortness of breath. So does that kind of answer that question for you?
Well, look, probably not for me. I mean, I start breathing rapidly sometimes when I first lie down, sometimes 15, 20 minutes after I lie down, and it might last for 15 or 20 minutes, but it doesn't last all night, and I don't have to change position for it to go away. So just
Do you go through any breathing exercises or deep breathing motions when you are in lying?
Same thing.
Do you go through deep breathing exercises when you are lying flat? Because I know that can help the muscles and your respiratory system, the conscious effort of going through different respiratory exercises like that when you are lying flat.
Yes, I mean, I do when I notice it, I start breathing in and out to see if I've got the same respiratory reserve. Perhaps that's what helps, I don't know.
I guess the physiology, if it does become increasingly worse, you know that if you do sit up, then it will become easier to breathe. And a lot of the times we will prescribe, even with people who we see who are within electric beds, they're usually in a high sitting position where they're in an incline and never flat. So that's usually a position that they will maintain instead of going completely flat because of the orthopnea that they would experience when lying flat.
Can I ask a really quick question? I know it's not directly exercise related, sorry, Nikki and Adina, but it's to do with neck supports and obviously the muscles in the neck. We've had a few questions lately from clients about what would be an adequate neck support. And obviously it's a physio domain, but some of our clients are regional and it's really hard to get a physio out there. So looking at supports that you might have had more success with in helping people to be upright. Do you have any suggestions?
Yeah, this is a big one. It comes up all the time. I think we actually were just discussing this last Friday because one of the physiotherapists in Brisbane, there was something in the UK that she used a lot, and there is a supplier in Australia, in Victoria, that does supply them. So most of the kind of more traditional neck braces, I guess people kind of report that they weren't enough. They were uncomfortable, can be too hot in, especially in Queensland, if you're living a bit rurally, because they're not very breathable. There is potentially even a bit of a document that we might be able to send to you that has a bit of a list of different ties, but there is one that tends to be a little bit closer with very small brackets that go right across the neck, which people have said a lot more comfortable and a lot more supported than some of the other ones out there. But again, some people prefer to have something that's a little bit more subtle, so they prefer those more kind of skeleton braces so they're not as obvious when out in the community. But yeah, potentially we can kind of send on a bit of a document with a few examples that you can pass on to people.
Thank you. I've already taken your email address down, so thank you.
Awesome.
Excellent. Okay, any final questions before we let everyone get on with their day? No? All right, then just on behalf of MND Queensland, Nikki and Adina, thank you so much for your presentation today. It was full of very, very useful information. So I'm sure everyone here got a lot out of it, and anyone that will be able to access it on our website in the future will continue to do so. So really appreciate that.